This meeting is being recorded.
Hello, everyone. This is Dr. Siddharth Dambar. We're about to start our webinar today. It's May 7th, 2025. For any of our audience that's currently on live, please let us know, or let me know if you can see and hear me clearly. Okay, great. Let's go ahead and get started then. Okay, wonderful. Thank you for joining me today. So today we're talking about regenerative medicine treatments. Just a little bit about what you will get from today's webinar. You'll learn about non-surgical treatments for arthritis and tendonitis that do not require surgery, what is legitimate in the field of regenerative medicine, how to choose the right regenerative medicine providers and clinics for your condition, and how regenerative medicine treatments fit in rheumatologic conditions as well. As we're going along, please leave any questions you may have, and I will do my best to answer as we are going along. In addition, after we're done today, if you want to ever reach us, you can reach us at chicagoarthritis.com. In addition, you can reach us via any of our social media sites as well. Wonderful. So a bit about who I am. My name is Siddharth Dambar, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology as well as in regenerative medicine, as well as in image-guided injections. In practice since 2008, practicing regenerative medicine since 2008 as well, and part of the Regenix Network since 2012. The Regenix Network is the largest group of loosely affiliated physicians that are practicing regenerative medicine, sharing best practices, as well as protocols and data to really give the best results for our patients. So my personal journey into regenerative medicine really starts with my own shoulder. I played tennis at a competitive level when I was a teenager. I never really had any problems with my shoulder. As I got older, done with my med school, now starting residency, I had a chance to learn more about musculoskeletal ultrasound, or ultrasound to scan things like your joints and tendons, and found in my own shoulder that I had some rotator cuff issues. Nothing really major, but in my mid-30s, as I picked up tennis again, started to realize that that was now actually a problem. And in my experience, ultrasound kind of showed me that a lot of our traditional treatments that we were using for tendon and ligament injuries was not really adequate, which is what then got me more interested in other treatments and eventually regenerative medicine. So there's a lot of issues with traditional care for musculoskeletal conditions. A lot of traditional care is based on a model of using pain medications, traditional injections, masking the pain, and eventually waiting for surgery. There's a lot of problems with this model. To begin with, pain medications have a lot of side effects if you're using them chronically. Traditional injections like steroids and nerve blocks can help with pain relief short term, but they're not really fixing the problem, and they do have side effects long term as well. The masking the pain strategy is just a short term solution, but we should be really treating the source of the problem, which I'll be talking about a little bit later, but is really mainly instability and inflammation. And then the last thing is, if you're just waiting for surgery, there are risks associated with surgery. Whether you're talking about cardiovascular, neurologic, pulmonary, blood clotting, things like that. And so surgery is not a small thing, even though it gets done relatively routinely in this country. And so we really need better non-surgical options. So in searching for better options, we need options that are lower risk and avoid serious side effects. They should address the source of the problem, which I'll talk more about, but it's instability and inflammation or metabolic issues. They should actually improve the cause of the problem, and they should give you longer term improvement because they're working on the source of the problem. Great, just double checking, make sure there's no questions right now. Okay, great. So How does a rheumatologist consider regenerative medicine? I am a rheumatologist by initial training. There are dozens of different types of arthritic conditions, and there are conditions that affect the entire body. It's called systemic arthritis, inflammatory arthritis. Those kinds of conditions are ones where there is massive amounts of inflammation, and that's your primary issue in those kind of problems. And then there's degenerative arthritis or tendonitis, which is more wear and tear arthritis and tendonitis that develops over time. That's due to instability. So the keys here are you always want to be treating what is the actual cause of your problem. So if you have a degenerative arthritis or tendonitis issue, instability is your major issue. You need to be focusing on that. You treat instability by strengthening things around the joint. That can include through physical therapy and muscle strengthening. That can include by losing weight to reduce the stress on the joint as well. And then that can include things like regenerative medicine, where you're using your own cells to actually strengthen the soft tissue structures that are leading to instability. Now, the reality is that there is crossover here. So in inflammatory arthritis conditions like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, the primary treatments are medications that work on inflammation. Long term, these conditions do make you more prone to wear and tear arthritis as well, in which case regenerative medicine becomes a good option there. From a practical standpoint, when it comes to inflammatory arthritis, there's little data. There's a little bit of data that shows that PRP is helpful in rheumatoid arthritis, but the vast majority of data is more about treating the overall inflammation with medications, which is why we tend to go that direction for those kind of conditions. For degenerative arthritis and tendonitis, there's good data that shows that treating instability, which we'll talk about, helps to reduce pain, improve function, and actually reduce inflammation in the joints longer term as well. And so that's, at least as a rheumatologist, how I generally kind of look at how you treat these different types of arthritis and tendonitis conditions. So regenerative medicine is the process of your body's own, using your body's own cells to treat your arthritis, tendonitis, injuries, and back pain. If you think about how a normal healing process starts, so take something like a cut on your finger. What happens is you first have platelets that infiltrate the area. Those platelets then stop the bleeding. They then release growth factors, which then stimulate your local stem cells to then start a normal healing process. That starts with inflammation by bringing other cells and growth factors, and then eventually a cellular layering process, reparative process. That works very well for tissues that have good blood supply. For tissues that do not have good blood supply, and that can include things like your tendons, your cartilage, your ligaments, the discs, the labrum, the meniscus. These tissues are very, very strong and hardy, but if they've been repetitively injured or too severely injured, they tend not to heal very well on their own because of that poor blood supply. So in regenerative medicine, we are taking those same cells, your platelets and bone marrow stem cells, and then injecting that into damaged tissue by coordinating, and then thus coordinating a normal healing process that is typically restricted because of that poor blood flow. So why regenerative medicine? We'll talk more about this, but it treats the source of the problem. It treats your instability. It treats the inflammation. Certainly safer than surgery. These are needle-based procedures. They are not big open surgeries. Effective for most musculoskeletal conditions. And for those of us who are involved in regenerative medicine, strongly feel like 80% of what is handled by orthopedic surgery will eventually be handled by regenerative medicine. In the same way that a few decades ago, any kind of heart disease was treated only with open heart surgery, now the vast majority, over 95% of heart issues, 99% of heart issues, are treated with either medications, diet, exercise, and then eventually needle-based procedures. Less and less is handled through open heart surgery. The same thing will progressively happen in orthopedics and musculoskeletal medicine as well. So again, with regenerative medicine, we're optimizing the health of damaged cellular tissue. And we do that because when you have a joint that's been chronically irritated or damaged, that joint is no longer pumping out the right proteins or enzymes. By injecting your own platelets or stem cells, you can get those cells to start functioning appropriately as well. That's what leads to reduction of inflammation long term. In addition, by treating the support of ligaments, tendons, and other soft tissue structures, you get an overall structure that is stronger and more stable, I'll talk about that in a little bit, but that's called prolotherapy. That leads to more stability and better function. All of this leads to less inflammation, better function, reduced pain, better activity tolerance, and better quality of life as well. So a little bit about what makes a regenerative medicine expert. As you're looking for a physician who is doing these kind of procedures, there's a few things, several things that you need to be thinking about. Number one, your physician should be a musculoskeletal expert. What that means is in medicine, you cannot be an expert in everything. So if your physician is treating somebody's high blood pressure or hormone management in one room, then somebody else has erectile dysfunction, then they're coming to you to treat your knee, that's not a typical musculoskeletal expert. You want someone who's really focused in on joint health. Number two, they should be a non-surgical musculoskeletal expert. Our surgical colleagues are very good at surgery, but the things that you need to be a non-surgical expert includes a lot of image guidance, utilizing x-rays, ultrasound to guide all your procedures. To do that properly, you really need appropriate dedicated training for that, which our surgical colleagues do not get. It's just not part of their practice. So our colleagues who are doing any of these procedures blindly, where they're just sort of palpating your joint and try to stick in a needle, that's not appropriate for these kind of treatments. You need to use image guidance. Next is your physician should understand that inflammation acutely is helpful to help you heal. Chronically, it's a problem. But I find some of my pain management colleagues will utilize steroids and nerve blocks to treat a lot of conditions. And then secondhand, we'll say, well, maybe consider regenerative medicine as well. The problem with that is by pumping you with more steroids, they are reducing your body's natural way of healing from an injury. And so understanding how to utilize inflammation to your benefit is key as well. The next is understanding that there are different types of biologic treatments and how to fit that for you in a personalized treatment plan. A lot of my colleagues who do these procedures, they take a one-size-fits-all approach, meaning they have a centrifuge machine that makes product X, and that's what they use for everyone. The reality is that based on what your issue is it joint, is it tendon, is it ligament, based on your age, your other medical issues, they should be varying the kind of treatment that you're getting. Meaning you shouldn't be getting the same platelet procedure for everything. You should be varying it based on what your problem is. And then they should understand how to utilize prolotherapy for treating instability. A lot of my colleagues, when they do these kind of procedures, for example, treating a knee, they'll just inject the joint. They're not treating all the other structures around it. The problem is that if they don't understand what's causing your issue, let's say instability, if they don't treat all those other supportive structures, you're not going to get the right kind of outcome. And then they should be transparent about your results and candidacy. I have plenty of colleagues who are relatively new to this and don't really understand what the data is. That's a problem. If you've been in this long enough, you'll realize where the data stands, what makes somebody a good, fair, poor candidate. They should follow your outcomes long-term. It should just not be doing a procedure, never seeing you again. And they should be able to guide you through this process. They should not just be doing a procedure here. They should be able to talk to you and guide you through this appropriately. So some basics in regenerative medicine that are important to understand. You need to understand some basics in terms of not only the science, but also regulatory and what are practical things. Number one, is this legal? Absolutely. There are some very strict guidelines from the FDA, and here's kind of three big ones. Number one is, should be using your own cells, not somebody else's living cells. That's what's legal in the United States. Number two, and that's for practical safety reasons, all right? Like the data for all this comes from using your own cells, not from using anybody else's cells. Number two, your cells should be processed and injected the same day. They cannot be overly processing this, and they should not be saving this. Those are like for use at a later time. Your cells have to be processed in a safe and compliant way and then utilized and injected the same day. Number three is that we're treating orthopedic issues, we're not treating other things. So if your physicians are treating things like autism and kidney problems or whatever, there's little data on that, number one, but number two, that is against the rules by the FDA. So what we can treat are orthopedic issues. Next kind of question that I often hear is, if I'm older, should I be using somebody else's cells? And the answer is no. The data shows that for the vast majority of orthopedic conditions, there's very good evidence that using your own living cells is effective. And then is there an age limit? Simple answer is for 95+% of what we do, there is no age limit. The data, published data shows that for most areas that we treat, your age does not seem to make a difference in terms of your ability to have pain relief and functional improvement. The one exception is hips, where if your age is over the age of 65, your outcomes can be worse. But everything else, there is no age limit. We talked a little bit about what kind of doctor does these treatments. They should be focused on musculoskeletal conditions, non-surgical musculoskeletal treatments, and they should be a proper regenerative medicine expert. Can these treatments help if you've already had surgery? If you've had like knee arthroscopy or lower back surgery, these treatments can still certainly absolutely help. On the other hand, if you've had joint replacement, where now, let's say your knee's been replaced, where now instead of having your own bones, now you have metal, they've kind of amputated the joint, now they put in metal, we can't inject into the joint there. If there's more of a nerve issue, we can treat that, but we're limited for anything else because if there's metal there, if there's hardware there. General rules that I try to guide people with when it comes to orthopedic surgeries is number one, always try to keep your own anatomy. They should avoid surgeries that are just cutting out tissue and not trying to fix something. There's a lot of arthroscopy surgeries that do that. It leaves the joint overall more unstable long term. And then if you've been recommended surgery, always get a regenerative medicine treatment option just to see if you're a good candidate for something that does not require a big open surgery. So we're going to talk about some key regenerative medicine treatment concepts that I think are important for you to understand. The first is stability. There is this concept in architecture called tensegrity. But it means that if you have individual units that separated are very weak, if you bring them in close approximation and then compress them, they are much stronger together. The overall unit is much stronger together than individual units separately. This concept in medicine is called biotensegrity. So prolotherapy is the idea of injecting your own cells or other solutions into those soft tissue supportive structures to strengthen and stabilize the joint. The key is you have to treat all the different layers to get that kind of effect, and understand that there's a progressive strengthening over time. For most of our treatments, you should be noticing early improvement at 1 month and getting better for several months afterwards, and that will maintain for, depending on the treatment, that'll maintain for some time. This leads to longer lasting results and better results as well. So prolotherapy, you may have heard about this in other from other places, but it's both a concept and a treatment. As a concept, the idea is that by strengthening the overall supportive structures, you get a better joint functional unit that is stronger and more hardy and less painful and better and more functional. From a practical standpoint, in a treatment standpoint, when we talk about prolotherapy, there's basic prolotherapy where we're using dextrose or sugar. That is the original regenerative medicine treatment that's been around for decades. I think like 50s or even earlier than that. Then there's the advanced version of that where now we're using your own cells. So when we talk about the different treatment options in regenerative medicine, you have milder treatments like dextrose prolotherapy, where you have to get treated once per month for 3 to 6 treatments. That'll give a good degree of relief. You then have platelet-rich plasma, which we'll talk a little bit in a moment. That's a more moderate level treatment, generally repeating treatment every 6 to 12 or 24 months, depending on how you're doing. And then there's your own bone marrow-derived stem cells, where it's our strongest treatment, where now, if you'll do well for a longer period of time. And generally, if you need to repeat treatment, that might be in the 2 to 5 year mark, hopefully 5+ years actually. This is a case study of treating somebody's lower back, an older gentleman who'd already had lumbar laminectomy surgery ×2. It means that they cut out the bone to make room for some of the nerves. Still having pain, very common problem that we see, unfortunately, that people who've had back surgery still having pain. Prolotherapy way of treating things, we treated his ligaments, facet joints, muscles, and epidural space, treating the whole spinal unit, not just the epidural space. Initially treated with his own blood platelets. He had mild relief to begin with, about 30% pain relief. Eventually, we escalated to using his own bone marrow stem cell protocol. which happens sometimes in folks that have had prior surgery. Sometimes they need a stronger treatment. And he's now 75% better and doing much better in terms of function as well, a good outcome. Orthobiologics is our next kind of concept to understand. These are the cells, the biologic cells and tissues that are injected into damaged orthopedic tissue. Again, use your own living cells, not somebody else's. That's where the data is. Number two, this uses a normal healing process, which we talked about. So platelets are the first line option for orthobiologics that you should understand. Again, platelets are critical in that they start the normal healing process in an injury. They use focal inflammation. They stimulate your own local stem cells. There are different types of platelets out there. There's not just a one-size-fits-all platelet process. So platelet-rich plasma is the process where we take a sample of blood from you, concentrate that into a high concentration of your own blood platelets, and that's what we re-inject. There are different types of platelet-rich plasma. That picture you see on the screen, the red platelets are a bit more inflammatory. The amber platelets are not as inflammatory. We tend to prefer the amber-colored platelets when it comes to platelet-rich plasma, when it comes to injecting joints and tendons. Sometimes we'll use the more red-colored platelets if we're injecting into more muscles. There's also what's called platelet lysate. This is where we take the platelet-rich plasma, crack them open, and just take the growth factors from that. We tend to prefer that for more nerve-related issues. So the type of platelet preparation that you get should vary based on what your issue is. But in addition, if you have more arthritis, you want a higher concentration of platelet-rich plasma, not a low concentration. And if you've got more medical issues, you'll want a higher concentration of platelets to get a better response. A lot of my colleagues use a one-size-fits-all approach. That is such a problem because it's not going to optimize the result for you. And if your physician is doing something where they're giving you 3 platelet-rich plasma injections once per week, that is a common protocol. The problem is that that's using a very low concentration of platelets. If you're using a high concentration of platelets, you'd never give it that often. It's just too much for the joint. You want to let the joint rest for like at least a month. And so very important to understand what kind of platelets that you're getting. That may seem like you're getting into the weeds, but it's a difference between getting a good result and really an inadequate result. It's a case study, an individual knee tendonitis. He's a cyclist. It's a regular guy, middle-aged guy, cyclist, referred to me by his sports medicine physician because he had persistent patellar tendonitis despite physical therapy and conservative options. The ultrasound image on the right, not sure if you can see my arrow, but that's the patellar tendon, all right? And it's attaching to this white structure. That's the patella, the kneecap. The little kind of bone spurring here, those are enthesophytes. It's a sign of stress on the tendon. It's a sign of patellar tendonitis. So in his case, we end up doing platelet-rich plasma twice. This picture on the right is a needle going into the patellar tendon, hitting the exact right spots. That's the right way to do this, not blindly doing this. After 2 treatments, he did great, back to his full capacity. I saw him 3 years later. Now his other leg was a problem. He had a hamstring strain. Again, treated with platelets and did great again and back to full activity. What I like about this case is, number one, showing a little bit of ultrasound images, I think is helpful to understand how we're doing this. Number two, the value of platelets in this kind of condition, especially soft tissue injuries. And number three, seeing how you can repeat treatment for that same area or even treating another area down the line as well and how well people can do. The next orthobiologic to understand are stem cells. These are the main cells that drive tissue repair and recovery after an injury. 100% using your own cells in America. And number two, what is legally allowed in this country is bone marrow-derived stem cells. That's what's legally here. If you hear about fat stem cells, there's a caveat here. The enzyme that's utilized to free the stem cells from the fat, you cannot legally use in the United States. So that's not what's happening. That can be done in other countries, but not in the US. The FDA has concerns about the safety of that enzyme being used in humans. You may hear about people using adipose or fat. The main benefit is, or the way that we'll use it is for structural support. Let's say you have a tendon tear, it's a bigger tear, and we want to inject not only your own cells, like your own platelets and bone marrow stem cells. We'll add a little bit of fat as well, because there is some structural support that it can be helpful with as well. You may hear about, in this country, amniotic umbilical cord cells. Understand that the way these can be sold in the United States is that the cells have been highly processed so that there's no living cells remaining in there. There's only growth factor. So you're not getting a stem cell treatment, you're getting a growth factor treatment. If you want a growth factor treatment, just get your own blood platelets. That's number one. Number two is you may hear about umbilical cord cells or amniotic cells being utilized in other countries. There's almost no data on the safety of that. You may hear of people trying that. I would just say be aware of the limited medical evidence of that safety, although it may still be beneficial, but there's kind of limited peer-reviewed evidence of that. Lastly, you may hear about IV stem cells, again, in other countries, no proven benefit for orthopedic conditions. When you think about it, when you place an IV and you then inject fluid into the vein, when the blood is going back to the heart to get recirculated throughout the body, it then gets pushed to the lungs to get oxygenated. When those cells go through the lungs, they get caught up in the normal filtering system of the lungs. And so you're not really going to get a dramatic effect in your joints, which is what we're talking about today, joints and tendons, with IV stem cells. There may be some anti-inflammatory generalized effect. I've heard of that, but it's not really the right way to do this. You should be treating the specific joint that needs to be treated. What I generally try to guide people when it comes to decision making for these kind of treatments, because how do you decide which treatment to use? Number one is, what's your severity of issue? The more advanced the issue, the stronger the treatment that you'll need. Are there any medical contraindications? Let's say you have active cancer. I would say probably better to avoid using your own bone marrow stem cells then. Even though the evidence does not show that's a problem, I'd probably sway against that. And then also understand that there's a difference between an initial treatment and a booster treatment. So let's say we've treated somebody's knee with his own bone marrow stem cells. He's doing great. He's 3-4 years out, having a little bit more pain. We may just treat him with a booster platelet treatment rather than full stem cell treatment again. And then, of course, there's cost considerations as well that vary between these treatments that you should be aware of, and your treating physician and clinic should be upfront about that as well. When it comes to outcomes, here's some key things. First off, yes, we can actually improve your pain and function even in advanced cases. What about improving how your X-ray and MRI images look? If you've got advanced arthritis, we cannot change what that looks like on your imaging. I can't get it to look like what that imaging would have looked like 20 years ago. We can definitely help with your pain and function, though. We can make a huge impact in that, but I just cannot make the images look different. If you have a tendon tear or ligament tear that's less than 2 centimeters, I'll show some pictures in a moment, that can still be improved, which is kind of impressive. If you have swelling in the joint, that can be improved. If you have swelling in the bone from arthritis, that can be improved as well. If you have a condition called avascular necrosis, which is damage in the bone, if you catch it early, that can still be improved as well. It's more chronic. You can't really reverse that. You can still treat the pain and function, but you can't necessarily reverse the damage in the bone at that stage. Another common question I hear from patients is, can we treat bone-on-bone arthritis? This term bone-on-bone arthritis is terrible for a number of reasons. Number one is that it's not a real term, all right? It's a term that physicians use, but the number of times you'll see somebody who has been told that they have bone-on-bone arthritis in one knee, and yet they have full range of motion. How can it be bone-on-bone if you still have good range of motion? The other thing is, a number of times people have been told they have bone-on-bone arthritis in one knee, and then they're told that's one that they have pain in, and then they're told the other knee actually looks even worse, but there's no pain in that. Understanding that the images only tell a little bit of the story, they don't tell the whole story. So arthritis is a biologic condition. It's treatable with orthobiologic treatments. In particular, if your range of motion and function are still intact, good outcomes are still possible. Always, when it comes to bone-on-bone arthritis, there's some caveats. Number one, our improvements that we can do are pain and functional improvement, cannot necessarily improve what the imaging looks like. And number two is, if you've got advanced hip osteoarthritis, that is challenging. We'll generally refer that to surgery because the outcomes of that are much more variable as compared to our other areas. Treating things like knees and backs, the results are fairly consistent. I think our bodies are just made to handle a lot more stress in those areas, as opposed to hips where outcomes are harder. What about tendon and ligament tears? So this is a nice case. So partial tears, definitely. Full thickness tears, in some cases, yes. So here's what we mean. Let's say you have a tendon or a ligament, it's intact. If you have a little bit of strain, it'll still look intact. If you've got a partial tear, part of it will be gone. If you've got a full tear, it'll be like a cut through the whole thing. There are full tears that are still closely approximated, that can still be treated. There are full tears that are fully pulled apart, that need surgery. In the case of where it's fully pulled apart, after they reattach it, that can still be torn again. You should have them inject your own bone marrow cells into that tendon or ligament as well. If they're not comfortable doing that, obviously, work with a regenerative medicine expert. So this is an example of a 28-year-old man, ACL tear. He's a butcher. This is not a professional athlete. He was playing recreational volleyball. I saw him basically 2 months after he'd had his injury. I'll show his images in a moment. We use his own bone marrow stem cells. 3 months after treatment, no pain. He's starting dynamic exercise with physical therapy. This is now several years out, and he's doing great. Let me show his images, though. That's really exciting. So this image here, these are an X-ray image of his procedure. That's your thigh bone, that's your shin bone, that's the kneecap. That's the needle coming in, and what's lighting up in the middle of the knee is his ACL. What's nice about this is that to inject this, you cannot do this blindly. You can't even do this under ultrasound. You have to use high-level X-ray guidance. So his MRI images are amazing. So his left knee MRI, the arrow here is showing his ACL. It's very hazy, disrupted. The radiologist has read this as a full thickness tear. And that tear is right in this area where there's a lot of swelling and damage. When you look at his treatment, when you look at his MRI 3 months after treatment, you now have an ACL that's fully intact and linear, clean. It's a little bit of fluid around it, right? Just from some resolving inflammation. But the overall ligament is very clean looking. And the radiologist has read that as a fully intact ACL. Very exciting to see that. We can get those kind of results. It's a nice case study of a gentleman, middle-aged gentleman with, he's a contractor doing a lot of overhead activity as part of his work, rotator cuff tear, using his own bone marrow and platelets. The picture's on the left. This is an ultrasound. This is a tendon. This hole right here is the tear. This is a full thickness tear. When you look at him 3 months after treatment, you now have a tear that's filled in. So he's several years out and doing great. But again, exciting to see that kind of improvement after treatment as well. Interventional orthopedics, this is the concept of using image guidance, namely X-rays and MRI to treat, X-rays and ultrasound to treat orthopedic issues with your own cells. So this is a nice example of injecting into a rotator cuff tear. This is the needle, this is the rotator cuff, very small tear. This tear may look big on the screen, but the reality is that is 1 millimeter by 1 millimeter. To do that blindly is impossible. This is an example of injecting the shoulder again. So the needle, this linear structure, kind of black structure here, that is contrast, showing that we're injecting into the joint. And what's cool is you also have this little triangular structure, that's the labrum, injected into the labrum as well. To do these properly, you have to use image guidance. I showed these pictures before. The one on the left is an ultrasound image of injecting into patellar tendon. The one on the right is an X-ray image, fluoroscopy image as we're injecting into the ACL. That's how we do this properly. This is a AVN, ankle avascular necrosis study or images case study. Avascular necrosis is where the bone is starting to get damaged, and if you don't do anything about that, the bone will die and eventually the cartilage will get damaged as well. So this is a middle-aged man. He's a chef developing swelling in the joint, wear and tear arthritis, and avascular necrosis. We utilize his own bone marrow stem cells. That swelling in the bone is this right here, by the way. You can see my arrow. 3 months after we injected into the joint, the bone, and the ligaments, no more swelling in the joint, no more swelling or damage in the bone. Doing great. He's several years out and doing very well. Regenerative medicine treatments offer safe and effective solutions for your pain. Again, after we're done today, you can learn more at chicagoarthritis.com. Let me just quickly take a look to see if there's any questions that are coming through any of our live streams. So is this too good to be true? Look, there's data from Philip Hernigue. He's a French orthopedic surgeon that goes back to the 1990s. Regenetics Network has data since 2005. I've been doing this since 2008. I have colleagues who think that this is a new field. It's newish. It's been around for a couple decades. There are right and wrong ways to do this. My colleagues who were unaware of the data 10 years ago, who didn't think these treatments work, now say maybe it works. We're not exactly sure, but there's good data for a lot of things that we do. Right and wrong ways to do this. Your expectations should be grounded in reality, evidence-based medicine, so that you can be guided properly. How long do results last? Look, there's data that goes over 10 years, even over 20 years now for in some cases. What I tell people, however, is if you have a chronic condition, think a bit conservatively. I think a conservative expectation is that if you get a bone marrow stem cell treatment for, let's say, a chronic arthritic or tendon issue, you should get benefit 5+ years. If you're getting platelet treatment, you should get 2 years. The more severe your condition is, it may not last as long. You may need to boost your treatment earlier than that, but that is a realistic expectation about what you can get from treatment. Best ways to maintain your result after treatment: improve your biomechanics, work with physical therapy, use the appropriate joint supplements. Repeat treatment is additive to initial treatment. Initial treatment, you get a slow improvement. For platelets, that improvement will be over 6 to 9 months, even up to 12 months. For stem cells, that'll be 12 to 18 months, progressive improvement. At some point, you'll start to plateau. If you're not quite at your goal, repeating treatment, you're now starting at this higher level, you're now stair-stepping to a higher level than that. And then, of course, maintain ideal body weight will reduce stress on your lower back and the legs to reduce pain and arthritis development. Improve your metabolic health, which will help with inflammation. I believe in that so much that we have our own physician-assisted weight loss program to help patients with weight loss and inflammation as well. We talked a little bit earlier about what makes a regenerative medicine expert. It's a lot of different things. As in everything in medicine, your physician should be competent in everything that it takes to be an expert in what they're doing, not just dabbling in it. A bit more about how we do things here at Chicago Arthritis and Regenerative Medicine. We're focused on only non-surgical treatments for your arthritis, tendinitis, injuries, and back pain, starting with a proper thorough evaluation to look at what's causing your pain, correcting with low-risk interventions if possible. If appropriate, then advancing to regenerative medicine using the highest quality options from yourself, a plan that's specifically tailored to your condition and needs, and delivering those cells using the highest level of image guidance available. To learn more about how to get evaluated, you can contact us either through our website, chicagoarthritis.com, through our social sites. You can email us at admin@chicagoarthritis.com. You can even call us at our phone number as well. We're here to answer questions and to help out as well. Okay, a couple of questions here. Let me just get to this. We do work on hands and fingers. So as a rheumatologist, I tend to see a lot of hand issues. And so I am comfortable working with hand issues as well. Someone else asking about osteoarthritis of the hip. It's a good question. So this is a 67-year-old asking about their hip osteoarthritis. Can we use stem cells? Depends on how much arthritis, how much damage you have realistically. We look at some things as what are the odds of getting a good result. The older you get for hip osteoarthritis, not other osteoarthritis issues, but just hip osteoarthritis, the ability to get a better result is less. For folks who have lesser arthritis or still in good condition, still have good range of motion, they can still benefit from treatment. But as with everything, you have to look at what are the odds of getting a good result. And it depends on what exactly is your actual level of arthritis and what's your range of motion. Okay, somebody asking about how does insurance treat this? The vast majority of people, this is still an out-of-pocket expense. There are some exceptions, namely So we work with Regenix. They have a corporate plan. They have about 3,000 plus employers in this country where this is now part of their benefits plan. That's still a small number, but that is growing every day. And so we have more and more insurance coverage for these treatments through that. If you're interested in learning more about that, go to regenixcorporate.com. The other question you asked is trying platelets. You're currently getting gel injections every 4 to 5 months. The data shows that when you compare platelet-rich plasma to gel injections, platelet-rich plasma works much better than the gel injections longer term. The gel injections are a good, mild, low-risk option as well. Certainly worthwhile to try that, but the platelets do tend to do a better job longer term as well. Okay, good. Well, we're coming up to the end of our time today. Before I sign off, someone asking about Dupuytren's contracture. So this is an example where you have to really think about what Dupuytren's is, right? So I think if you have very mild Dupuytren's, I think that may still be treatable with platelets. But I think when you start getting to like where it's now contracted, I think that is more surgical, probably would benefit from surgery. Now, what's interesting is after surgery, Dupuytren's can recur. Like that's fairly common. It's probably worthwhile considering after getting treated, having platelets injected into the tendon as well to help maintain things. Yeah, you're welcome. Okay, wonderful. Well, listen, if interested with additional questions, contact us afterwards. You will get a link for a copy of this webinar. You can rewatch it, you can share it, and if there's any other questions, contact us at your leisure. And I hope this was helpful, and I look forward to helping if we need to. Until we connect again, I hope everyone has a good day and live well. Bye-bye.